Oh, you made a face cradle with your shirt? We can get you a pillowcase. So,
I'll save you.
that's very nice. If you need to, just throw some clothing on the table. It's your sheets. All right. So you told me you have all kinds of neck and shoulder stuff, actually symptomatic right now. Give a little bit of the injury history so we can hear that.
I had shoulder surgery in 2019, and it's worse than it was before I got the surgery. It's like a constant. Even when I'm like going on long walks, like it starts to get painful. If I put backpack on it, it hurts. And if I drive long, it hurts. And if I weight train, it hurts.
Is it your dominant arm?
Yes.
Yeah. It was a ligament tear, some kind of.
Yeah, I forget which one it was.
Yeah. But they went in, probably sutured it up.
Yeah.
But
I didn't go to physical therapy like I should have.
this is a common story.
So,
but you were a lifter, so you probably thought that through strength training
I was
itself.
Like going to spin class with a sling.
Hey, youth, it's good for you. But that's where sometimes, I mean, I was guilty of some things. I mentioned my whole like neck popping thing. You know, I knew better. What do you do? So the sensation. So this is also where some of the assessment can be like, if the sensation can be described when it hurts, like, can you describe it? Is it more stabby, burny, deep achy, any of that?
I would say like a deep ache, burning in some, like if I do this,
Okay.
and like push down here, this burns like all the way up to here.
Okay.
And then
Right where she wants to crack her jaw.
Burn all the way up. Okay.
Yeah, and then behind the jaw, it just feels super tight.
Any tracking down the arm?
When I go like this, it goes down.
What about activity? Like, can you do your exercises and stuff?
Yeah, but it does
Push-ups?
feel.
Push-ups are cruel. If you're gonna, we'll get into some of that, but you're going to be careful with those elevated
and then
butterfly
it
stuff.
feels like when I do like stuff like this, it's like stiff almost, and it like pops kind of. Even on this side, it does that too. I think I just got kind of bad shoulders, maybe in general.
But it's the loosest joint in our body. A ball and socket joint that not only has the most range, but it's also attached to a scapula that also can do all these other things.
And then it hurts under here.
Okay.
And then there's a bunch of stuff. If I'm like laying flat and I extend, it goes like here.
Okay. And is that a burning?
Yeah.
Okay. Burning.
Cut it off.
Assume,
Right.
Done. Solution. Can mean nerve. It can also mean connective tissue. So it can mean myofascial. Maybe it's a little bit of both.
Okay.
Start with assuming it's nerve and hope that it's not. Okay. But this is a grand collection, and your posture is such where you got a nice, good asymmetry here. Even look how the clothing is set. All good indicators, right?
I can feel it.
It always drives me nuts. Like that happens with mine, and like it'll track over like this, and I'm running and I'm trying to like get it. So, but this is a perfect candidate related to just how it's going to be a collection. There's a myriad of things. There's something capsular, something scapula, something neck, maybe brachial plexus, and then even jaw. And you said you pop the jaw. Do you get jaw pain too?
Yeah. I don't know if it's because like my wisdom teeth are growing in. If that could be a factor.
That doesn't help anything.
Yeah. But yeah, I've always had jaw pain.
And more on this right one?
Yeah.
Okay. Yeah.
This one doesn't hurt at all right now.
Dominant. You do have a dominant side jaw. So, I'm not an orthodontist or anything, so not a dentist to give you, but there is something to. This is where like your health messaging, there's layers, but there's stuff about like trying to get like the tongue position on the roof of the mouth and keeping the jaw somewhat lined up, and you can play with like how much you can track one way or the other. And if you feel resistance, you can show some self-care here, which I'm more inclined to do for people with like TMJ jaw stuff, is drawing their attention to it. It's like you unlock your jaw just a little bit, And usually I just get to get the tongue out of the way, but there's something, I don't know how much there is behind this, but remember something about proper tongue position for your jaw, and it's like tongue against the roof of the mouth, blah, blah, blah. And then playing with how much you can shear one way versus the other. And if one feels like it's more than the other, get your hands on there. Just below the cheekbones and kind of feeling one way versus the other. And feeling if you have more versus.
This side, like, I think feels more like tone.
Yeah, and you can do some muscle energy stuff with that. Like find the spot, find a position where it doesn't hurt, and kind of move around. Now, what I'm not going to show as much working on masseter. Something I'm more inclined to show on people for themselves. I'm going to show is working on the temples and how that also will be activated related to all your jaw functions. So masseter and temples are related to the jaw. It's an initial easier interface to work on temples, and it isn't nearly as ouchy. So if you really need to, you can go after masseter, reaching in and pinching it on both sides. That's its own journey. The rest of it, we have shoulder elevated and neck laterally flexed. So in order to elevate the shoulder, we're talking about upper trap, levator, scapula. There is some internal rotation and protraction. That's going to be your pec minor, serratus anterior. The even positioning of the hands, a little bit more pronated and or internally rotated, that would be subscap. Ideally, this all proves correct. I'm looking and going, all right, this is the formula. Probably scalenes, levator scap, pec minor, subscap and serratus, and a really good neck massage. And, you know, and it ends up being all of it. And especially for that brachial plexus pathway, the scalenes and pec minor, it's worth looking up. The images online, if you look up scalenes, pec minor, brachial plexus, it gives you a really cool sense of how that has to come out from the neck, under the clavicle, past the scalenes, under pec minor, and then down the arm. And how if one gets bad enough, just creates a whole bunch of stuff. So, plus there's an old joint injury. And we'll see. We'll see what happens. All right, so let's start you in prone. Face down. Yeah, we're good. Knees up. Now, first things first, are you comfortable?
Yeah.
How's the head position? Could we shift this at all for you?
It feels good.
Okay. Now, shoulder position. Are you more comfy like this or more comfy like that? Is this the symptomatic side?
Yeah.
Yes.
Like this.
Yes. That's more comfortable for me, certainly. It's a safer position for the shoulder joints. So if we can get them here, and there's problems here, it's usually your better starting point. All right? So, with the scapular stuff, and don't worry if you guys do want to come up and look with a smaller crowd here. You can start just palpating and seeing what we got. And if I can, I sprinkle in such a, oh, there it is. That's a good glued down aspect of where latissimus dorsi comes over the inferior angle of the scapula. That can get, it's one I don't see a lot of, but it's oddly enough something that I've felt in my own body. So I kind of go, oh, that seems very familiar. So here, and it's just, there's that resistance. I'm trying to find that inferior angle here. Here's my scapula. This is even the right one. And pulling, seeing how much upward, downward rotation I can get. So that matches. This isn't the right position for that interface. So there's a ropiness right there. I may find a way to work on that a little bit in this position just because I can palpate a lot of it. So then I started thinking, now all of this can be considered assessment. statement is no mindless rubbing, right? Try to always be thinking about what you're doing and how it could help the area that is symptomatic. So here, what I'm doing is at the very least balancing out these two areas. But I can be comparing the tone of levator, scap, and upper trap. And there's certainly more all on that right side. Now all that pressure okay?
Mhm.
Nothing. Ideally this all should just feel good. So then I think some more, and I search. That's okay. So when you guys first learn your routine, I try to simplify it and show, like, start with this forearm and work your way down here, and then do a flip. Use this form. It lines you up a little bit better, but sometimes changing which forearm naturally focuses your pressure either closer to the spine, or closer to the scapula. So if I use this arm, I'm going to be closer to the spine. And so I can just do some either passive work here, roll the shoulder around and feel how it's doing. I always assume, I usually assume in these situations that rhomboids are long, but the muscle underneath of them, serratus posterior superior, which is a inhalation respiratory muscle. It's deep, but it lives right underneath rhomboids. And I just tend to assume it can be a lingering part of something negative when you have shoulder stuff. Now I'll tend to encourage upper chest breathing anyway. So if I change my arm, now my contact is going to be closer to the edge of the scapula. And I can even steer where I'm actually over on the other side of her head, trying to pull all those structures away from the spine now. So it just gives you some additional angles, ways to focus using forearms. You can use the forearms as much as possible, because once we get to using our hands to do the deep release stuff, I'm going to be happy that I saved my hands.
Do you still feel the ropiness?
Yes. Well, we'll see once we post assess afterward, but.
Can you show me what ropiness
Oh,
feels?
yes, yes. Let me get before I smash. Let me do that. So there was, I'll have to come back off. Am I finding anything there?
Mhm.
Okay. I'm just confirming and relax. And I don't know, you can be more precise, but I like staying more ambiguous with my statements. Did that feel like something? Did that feel like something? Where were you? Right through there, you're gonna feel, yeah. So right where the line of the shirt, the seam of the shirt is, and kind of pull,
Okay.
and then just start lower. You can kind of see my hands.
Mm-hmm.
I'm gonna give that a palpation.
Forgive me.
Any contact
Right there?
can be helpful.
That was pretty dramatic.
Yep. So that's latissimus dorsi.
Right.
So the question then becomes, what's the angle that's going to give me the best
I got you.
point to actually
Because you're sitting
interface
there.
with that? No, that's a little, well, especially when I compare and contrast. Like that's not. Now some people can be ropier than others, but so all right. Now I'm technically working on all this stuff that's maybe a little long right now, but I just search. Okay, tell me what I find.
It feels.
Oh, like something.
Yeah.
So, to give you the easier point, easier intervention to use here, is to use the breath. Because I know here we have that serratus posterior superior. So just big giant inhale. For this region between the scapula and spine, especially when you're around the rhomboids. And then going one step deeper, and it can be pretty intense, but it usually should feel like, oh, that's doing something. Serratus posterior superior. So she's already doing some good breaths. I felt maybe something shift there. If I wanted to take this a step further, the most aggressive version is having a person cough. But not doing that, we will encourage a big inhale all the way in. So
Am
there.
I supposed to do that?
Yep.
Okay.
Big inhale all the way in. At the peak of the inhale, hold your breath for just a couple of seconds. The holding of the breath acts as our contract, and then let go. Nice long exhale. The holding of the breath just helps, think of it like an isometric contraction for the respiratory muscles. You can use that anywhere related to, especially when I identify something that I know is an inhalator. So it lifts the ribs during respiration. That's one where I'm trying to always encourage better belly diaphragm breathing. That's a common one. And then you could use that anywhere in the neck too. Quadratus lumborum, scalenes. Could use that. Using the breath plus holding of the breath as an isometric contraction. But that's related to rib movement and breathing more than like posture and functional like gait. Drop down on a knee. Soft fist. Side lying position will probably be our best interface. But I'm just looking for, now it's the lateral border of the scapula, moving inferior. And then I just use my soft fist. I don't think I'm quite there yet. Anything there feel?
Yeah.
Okay. Too much? All right. She's gonna be one where probably wouldn't flinch up in such a way. So I'm already confirming I need to confirm that she really tells me if and when it's ever too much. So here I'm gonna have you bring your shoulder this way, hold it right there. Now I'm gonna push your elbow, but don't let me move you, okay?
Okay.
Okay. That shouldn't hurt. Okay, slowly back down. Nice and easy, slow back down. So I positioned the arm like this and then pushed up on the elbow to activate latissimus dorsi. So up, okay, push, and down, nice and easy, slow. Now is that changing or staying the same?
It feels a little better.
A little better. I'll do one more. Okay, push. And let go. Nice and easy. And in this position, I can just use that arm like a lever, encourage a little bit of that rhythmic shoulder rotation, back and forth, back and forth. All right. Now, this part of the shoulder joint, I struggle getting it as easily in side lying. The idea is that where there's teres minor and teres major, and even tricep attachment, there's deltoid sitting on top of this, that line can get adhesion-y, for lack of a better word. And this angle sometimes just gives me better leverage. You could do it in side lying, but here I'm going to try to bring a forearm in, right down on top of those. And then the action I can then use is just straightening the elbow all the way out into full extension, and then rolling the whole arm into external rotation and internal rotation. So back down. I've used this as a way to kind of deal with maybe a weird teres minor, infraspinatus, posterior capsule, itis. The scapular nerve is hidden in here, so like anything, when we work here, I'm gonna check in with her that I don't cause something that feels too nervy, or we start cutting off circulation. So, come in, pressure, 10 minutes just right.
That's good.
Okay. And nothing nervy, still circulation. Good. I'm gonna straighten the elbow all the way out. Okay, that's real strong. So tricep does come up and attach on the scapula. The short head, I think. No, the short head's no. Stays on the humerus. Back down, nice and slow. So that's what I'm ultimately using though. Although I may be affecting the teres muscles, what I'm really more worried about here is unsticking the layers of muscle. So connective tissue as opposed to individual muscles. And so I'm using is the shear that gets caused when she contracts, shortens triceps. Okay, shorten. All the way, full extension. That was a little smoother, a little bit easier. I'm gonna have you rotate your arm as far as feels comfortable one way. That's external rotation and supination, the other way. Pronation and internal rotation. Okay, switch, go the other way, turn all the way over. Good, switch, down, and good. And relax, back down, nice and easy. Good. Now, the shoulders too, especially when there was something in this ligament tear that we're uncertain of, like could ask the client to maybe search in the medical records and see exactly what tear we're talking about. But anything truly joint related there, if I can get my hand pretty much on the acromion of the scapula, I can use that as a place to, you just relax there, to just rhythmically rock that glenohumeral joint. And this is a place in particular. I mean, I've shown on the low back and other areas, but I guess I'm a bit oversold on this because I had such a good response with that client that had the really bad osteoarthritis of the shoulder. But this rhythmic rocking of that glenohumeral joint, trying to just encourage synovial fluid to get distributed more effectively, and that rhythmic oscillation can be, if you do it long enough, especially rhythmically, mine's maybe not perfect rhythm, it can, for lack of a better word, sedate the muscles. Rhythmic oscillation can be a great way to just reduce muscle tone and not have it be too like pressure focused. Eventually it gets boring. And then you go, all right, I'm sick of doing that. I'm gonna move on. Roll, 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 roll. We're gonna compare the scapulas again and see. And I would like to think I do see it's still up, but I think that the protraction is slightly reduced.